Dr. Anita Borges is a surgical pathologist of repute and has spent over 40 years as a cancer pathologist in the UK, USA, and India. Dr. Borges currently holds the posts of Head of Histopathology at SL Raheja Hospital and Laboratory Director, Center for Oncopathology, Mumbai. Dr. Borges is famed to be the last word in histopathology and oncopathology in India. Her numerous publications showcase her research on head and neck pathology, metastasis and lymph nodes, and all other aspects of oncopathology. She is known to be a passionate teacher who advocates for an educational system that is centered on thinking and problem solving. It is with great pleasure that I welcome Dr. Borges to deliver her lecture.
Thank you so much. Thank you, Simanpreet, for that introduction, and thank you, Vandana, for having invited me to this fascinating conference, where young people present their cases and open themselves up to being questioned. I think there's nothing better than that for anybody to learn. Well, I'm sure that people are wondering what this little talk is all about. I'll just tell you that as we go along, I hope you will agree with me, because this is something that I have come to understand over all the years that I have been doing diagnosis, not just first-hand diagnosis, but a lot of second opinion work. And this brought me to this understanding that all tissue diagnosis is based on the interpretation of a constant artifact. And when I say tissue, I mean not just histopathology, although much of what I will talk about is histopathology, but we must remember that cytology is very much a part of tissue diagnosis. If you have to have an essential, what is essential for any diagnosis? Think about it. You need a good description. Of course, you need appropriate investigations. Very important is the context in which this whole diagnosis is being made. You need to put all of these together and analyze the description, what your observations are, etc., how your investigations, what kind of information you've got from your investigations, and of course the context. Analyze all these, come to a list of possible diagnoses. Then of course you narrow down these diagnoses based on what else you may have found out about the patient or the radiology, or maybe even additional investigations that you do, and there is a final diagnosis. But I've put a good description in red. I've highlighted it. Why? Because remember that a good description starts, whether it's gross description or even a histological or a cytological description, really starts the whole process of a diagnosis. At least for us histopathologists, it does. And what is a good description? A good description is about making observations and then interpreting those observations. And you put both your observations and your interpretation together and finally make a diagnosis. Now, I just give you a couple of examples. One of them, at least, will be from oral pathology, but I'm a medical pathologist, and therefore many of my examples will be taken from medical pathology, but I'm sure it will be obvious to anybody who is a student of pathology or who does histopathology. So here is a lesion that was taken out of the soft tissue of the thigh of an adult person, and you can see that there is a little bit of muscle there that looks a little deep red, and then there is this tumor. And when you describe this, now again, it's observations that are going to be made on a gross examination. You would write this down as a well-defined soft tissue mass in muscle with a yellow mucoid appearance. I'm sure everybody will agree with that, and there will be no dissenters. Then you come to the histopathology. And how would you describe this histopathology? Make an observation. And you'd say that you can see it is well circumscribed because you see a rim of muscle at the periphery, and it's well circumscribed, it's not encapsulated. Almost acellular, and you can see that there are very few nuclei in this mucoid lesion in skeletal muscle. Now we know that there's no mucus truly in skeletal muscle, and therefore when you are going to interpret this gross and these microscopic observations, you will say that this is a paucicellular myxoid tissue. That's what we call mucoid material that is being produced by mesenchymal cells in the stroma. So this is paucicellular myxoid tissue. That is what we call an interpretation based on the observations that we have made. And finally, of course, when you have made that interpretation, there is only one diagnosis that is possible, and that is an intramuscular myxoma. I'm sure you as oral pathologists know that this would fit for a myxoma anywhere in the oral cavity, even a myxoma in the bone. It's all myxomas have more or less the same observation. All right, so from observation, we went to interpretation, and finally to a diagnosis. Let's take another example, and this could apply to oral pathology. You have these two pictures that look more or less the same, right? If you had to make observations on these, what would you say? That you would say this is cytologically, both of them are cytologically bland. They're composed of large, flat, keratin-forming cells arranged as a pavement and showing an exophytic growth pattern, right? That is the observation. Now, making these observations, anybody even listening to this would know that the interpretation of this observation is that this is a squamous proliferation. Very good. But now we need something more to decide what this squamous proliferation is. And when you look at it, if you know that the one on the left-hand side is a skin lesion and shows these steeples, you know, these spires of, which you can see here, these tall little spires of squamous cells, whereas the one on the right side is an oral lesion and shows broad infiltration. You can see the infiltration that is present in the stroma. You have you have the observations, you have further observations, and then you come to the diagnosis. And then the diagnosis is on a viral wart because it's on the skin, and the one on the right is the well-differentiated invasive squamous carcinoma. So we've got everything here. We made the observations, we made the interpretation, we added further observations and a context, and we have come to the diagnosis. Now I'll show you a lymph node. Now this lymph node is a biopsy, and I think all of you can see that it is a lymph node. And I'm sure everybody is saying, ugh, horrible. Yes, now this lymph node came to me for a second opinion. It was reported elsewhere as Hodgkin's lymphoma, okay? And my opinion was, yes, possible, but this requires another biopsy for a definitive diagnosis, because believe you me, the treatment of Hodgkin's lymphoma is not a joke. It requires several months of toxic chemotherapy, etc. Now, the final diagnosis after another biopsy was Hodgkin's lymphoma. So I'm sure it's going through your mind. The first diagnosis was right, despite the fact that the person who was doing the second opinion, that was me, was not able to make that diagnosis or was not confident about making that particular diagnosis. Okay, so the question that is one has to ask is, why is it that one pathologist made the right diagnosis on this material and the other would not, or in some cases could not? Now, herein lies the answer. And the answer is simply this: all tissue diagnosis is based on the interpretation of a constant artifact. Right? Let's look at that a little more carefully. Observational criteria, all observational criteria are based on a familiar baseline artifact, because whatever you say, that tissues, when you take them out of the body, are not in the pristine condition in which they were. We as pathologists do a lot of things to tissues. We fix them, we process them in a whole lot of reagents, we then stain them, etc. And each of these steps is introducing an artifact into the tissue. And you know that if you are going to make observations, the artifact and that those observations have to be meaningful, then those observations have to be made on the basis of an artifact that is familiar to the person who is making those observations. And of course, in turn, interpretation is based on observation. So if you're going to make an interpretation, it's going to be based on an observation, and all those observations are going to be based on an artifact that we have introduced into those tissues. Now, those who are used to a particular artifact can make diagnoses that stump others, because others may not be used to looking at the sort of artifacts that a particular pathologist is used to. And this realization came to me when I was working in a lab in England. It was many years ago, and we used to get a lot of slides that very rich Arabs and Turks and people from Greece would bring with them, because they would come to take treatment at this hospital. It was the Royal Marsden Hospital. So we had to review a whole lot of slides so as to be able to offer a diagnosis on which, or to confirm the diagnosis with which these patients had come seeking treatment at the Royal Marsden Hospital. And believe you me, that this is now, I'm talking about more than 40 years ago, some of those slides were uninterpretable by pathologists, better pathologists than I, because I was just a trainee over there, by the pathologists who had to sign these out. And it was frustrating, because sometimes these patients had to be re-biopsied. Now, there was a day when there was another one of these slides. It was said to be a breast cancer. And honestly, my boss couldn't make head or tail of it, and neither could I, because the tissues were thick, they were, poorly processed, and, you couldn't really see good cytological details. And we happened to have a visiting pathologist from, the country where this patient had come from. And my boss said to him, "Come here and look at this slide and tell me what you think." And this little guy came, took just 10 seconds to look into that microscope and said, "Infiltrating duct carcinoma, sir." And both of us, both my boss and I, said, "Good God, how did he make that diagnosis?" And indeed, when the biopsy was repeated, it was an infiltrating duct carcinoma. And then the realization hit me that in the country from where he was, this is the sort of histology or the preparations that he was used to seeing, and on which he would make the diagnoses, in this case, the diagnosis of breast cancer. right? So it occurred to me then that everybody has an artifact that they get used to, and then their diagnoses are made based on that. So every breast cancer that he had ever seen was made based on this kind of material. There is another thing that I think we need to understand, that diagnostic criteria on the same tissue, so it can vary with the method used to obtain the tissue. Now, what do I mean by that? Right? Oops, this thing is not moving. Sorry, I see my thing seems to have stuck. Let me see if I can. Yes. So it is because I think that all tissue diagnosis is based on the interpretation of a constant artifact. You cannot use the same criteria for cytology and histopathology of the same tissue. And I think we all know that, but we never think about why is it that we can't do this. Now, here is carcinoma cells in a fluid aspirate from a cytic fluid. And this is, okay, stained with Giemsa, and that's, a cell block stained with H&E. But even if I had stained this smear with Giemsa, look at the size of the cells. Look at their, the nuclear features, and compare it to what the size and the nuclear features are after it has gone through processing, fixation, processing, and finally staining. So the cells have come from the same fluid. One is an aspirate, and the other one is has been smeared aspirate, and the other one has been processed and made into a histological slide. Here I'm showing you a bone marrow aspirate. On the left-hand side, you can see the same. It's an acute lymphoblastic leukemia. On the right-hand side, you have a bone marrow biopsy, which has gone through many other things. It's also been decalcified, okay? And on the left-hand side is a smear, and you can see the big nucleoli. You can see the processes that are from, that these cells have. But look at the same thing when you are looking at it, and even if you had put it under oil, I grant you that the left-hand side picture is under oil, but look at the right-hand side picture. Even if you put it under oil, you would never get the same size or the same nuclear and other cytological details that you saw. And we have introduced an artifact when we did fixation, processing, decalcification and everything else. And of course, there is an artifact on the left-hand side because those smears are not fixed smears, they're air-dried smears. And if you had fixed it, it would have looked different. So I hope I'm convincing you that our diagnostic criteria, our observations are very, very dependent on what artifacts we have created in the tissue. And I'm just going to show you one other case, and this is this. Many of you would not be familiar with this, but look at the nuclei. This is a papillary carcinoma of the thyroid, and these are fancifully known as Orphan Annie nuclei because of this character it's a cartoon character called Orphan Annie, whose eyes are vacant. So you see these vacant looking nuclei in this tumor, and we use this day in and day out to make a diagnosis of papillary carcinoma of the thyroid. If we don't see these nuclei, we're very uncomfortable about making this diagnosis. All right. So there is routine, and this is what it looks like when you have routine fixation and processing. But if I have to make the same diagnosis on a frozen section, and we do that sometimes because preoperatively they haven't been able to identify what the particular lesion was, and then we get it sent for a frozen section. Now, do you see the Orphan Annie nuclei? And I think, no, you can't see them. Okay, that's at a slightly lower power. This is a little higher power, and there are no Orphan Annie nuclei. And what do we do at frozen section? We take fresh tissue and we freeze it, and we cut sections. So there is no fixation, there is no processing through the usual things that we process stuff to. We just see this almost fresh, so to speak. Now, what happens if this frozen section block is then processed through, the usual fixation and processing? Do you still see the orphan-Annie nuclei? And they're not there. Okay, so how do we account for these orphan-Annie nuclei? They're obviously not there on the frozen section or the routine fixation and processing of the frozen section block. So it is some artifact that has been introduced into the tissue. It's an artifact of routine fixation. Yeah. So now you will be saying, so what is a good histological preparation that would allow for good observation? So what is this good? If somebody has a constant artifact and he's able to make a diagnosis of breast cancer and you can't, too bad. So what is a good histological preparation? And I mulled this over a long time. And this is, I think, that this artifact should be kept as constant as possible so that it is interpretable by the majority, not just some person, in one country or in one lab or people all over who look the world, who look at the same slide should be able to interpret it and make the right observations. So subtle features should be evident, okay? So it must be possible to look at subtle features. And serial sections of the same quality you should be able to obtain these serial sections. So it's not good enough that, you just cut some sections of the top and you can see something, and then the processing is so bad that in the rest of the block, you can't see this. And of course, very importantly today, ancillary techniques can be optimally applied. So I just ask you now, okay, this was the original lymph node biopsy. We got the lymph node biopsy repeated. And you can see the nodularity that you were seeing in the old biopsy. You can see it here in this biopsy, but you can actually, you get the feeling, although this is at low power, that I can see into this tissue. I will be able to see cytological details at high power. So you would not want to report on that one. And now look at the cytological details. This is taken at the same MAG, all right? Look at the scrunched up nuclei that you see over here. Everything has shrunk. Yeah, you might say, that there is a little big cell there and a little cell there, but look at the size of these nuclei here, and I don't think that there is any diagnosis that this is any doubt that this is a Hodgkin lymphoma. And I tell you, you can do immunohistochemistry and get some really good results if you have good histology. So that's what I would say. Now, I'll just leave you with this last example, right? Now, here is a biopsy of a lymph node in the neck, and this patient had multiple lymphadenopathy, okay? Make the observations on this, and you would say lacy network of holes of varying sizes with an amphiphilic rim around the periphery of each hole. I'm just, giving you these observations. And an overall, well, maybe you would say pinkish, perhaps amphiphilic hue, and there are no cells that are really discernible, okay? So what is the interpretation you will make of this? Somebody might say, sponge has been biopsied. Possible. Somebody else might say, never seen this before, so I can't interpret it. Or others might say that this must be tissue because a lymph node was biopsied and received for grossing. So then the thought comes, could it be an artifact of fixation or processing or both? And indeed it is. This is what happens when you have slow freezing and thawing. And this tissue, sometimes, instead of sending it directly to the lab, or maybe the lab was shut and somebody had to, sort of keep it cool, particularly in our part of the world, and it hasn't been in formalin, or people just do this, and it happens so often that I hate to admit that it can happen over here. This tissue was kept in the freezer compartment of a home refrigerator, then thawed and sent to the pathology lab. Okay, so what am I saying? That we can introduce artifact and lots of different artifacts, but certainly we don't want this kind of artifact where nobody would be able to interpret it. Okay, this is not the artifact, should be kept as constant as possible. Okay, so now just to recapitulate, all tissue diagnosis is based on the interpretation of a constant artifact. Diagnostic observational criteria are always based on a baseline artifact. The baseline artifact, whether it's a sphere or it is a histopathology, should therefore be kept as near constant and reproducible as possible. And this means that it should be, as I've said, interpretable by the majority, that subtle features should be evident, it should allow serial sections of the same quality, and it should allow ancillary techniques to be applied. But remember that some artifacts obscure the morphology completely. And so finally, I would say, to get a good observation and to keep this constant artifact, baseline artifact, the way that it should be, you need a lot of good things, okay, to achieve this good diagnosis. And you can see that it's right from how tissue is excised, grossed, fixed, processed, sectioned, stained, all what you do, okay? And you, of course, should have a good eye, good training, etc. And I'm reminded of an old ditty. It said, for the want of a nail, the shoe was lost. For the want of a shoe, the horse was lost. For the want of a horse, the rider was lost. For the want of a rider, the battle was lost. For the want of a battle, the kingdom was lost. And all for the want of a horseshoe nail. So thank you very much, all of you, for listening to this. I thought that we should talk about something a little odd and not absolutely run off the mill. Thank you.